also discuss the newer advances in diagnosis and the latest guidelines on follow-up. To discuss today, I think we have our eminent moderators today. We have Dr. Chandrika Anand. So we have Dr. Chandrika Anand, madam. She's our in charge obstetrician of our high-risk pregnancy clinic at Hobart Hospital, Anashankari. So I welcome you, madam.
Yeah, thanks, Abhishek. Glad to see so many doctors here, and I'm looking forward for an interesting discussion, interesting talk by Dr. Amrutha, and I want Dr. Navya to give her inputs. She has done FNB in high-risk pregnancy, Navya, and fetal medicine specialist. So I'll be listening to all the talks. Abhishek, looking forward for a good one.
Sure, madam. We welcome Dr. Navya as well. I think first we'll have a obstetric perspective of Down syndrome. We welcome Dr. Amrutha Shri, and Dr. Amrutha Shri did her MBBS from Bangalore Medical College, did her MD OBG from PJ Chandigarh. So she's on her MRCOG and FMAS. She's recently done laparoscopic fellowship as well. She's the in-charge gynecologist at Sham Hospital, Bangarpet. I think Bangarpet is fortunate to have such a eminent obstetrician there, such a qualified obstetrician at Bangarpet. We welcome you, Dr. Amrutha.
Thank you very much, sir, for your kind introduction. Thank you. I'm Dr. Amrutha. Today we'll be discussing about the obstetric perspective of Down syndrome. Like sir said, it is a nightmare for the obstetrician also, sir, because it is very difficult when the diagnosis is not found to be picked up in antenatal period, and all of a sudden we have a baby which is born with Down's phenotype. So we will proceed with the discussion. Okay. So Down syndrome is, as we know, is the most common autosomal aneuploidy with an extra chromosome at position 21. Now, this can be because of a translocation with other chromosome, or because of a non-disjunction error at chromosome 21. So in 1866, it was Sir Langdon Down who first identified that certain babies had a characteristic facial feature, and he called the face as flat. So these were eventually diagnosed as trisomy 21, and they were named after him. So the incidence in India is about 1:800 live births, and it's a most common inherited cause for intellectual disability, and hence it's a very important part of our antenatal workup. So we'll come to the case scenario. The baby is baby of Mrs. M, who was delivered by a cesarean section. As sir mentioned, it's an outborn, which was referred to Obam Hospital with features suggestive of Down syndrome and hyperbilirubinemia on day 4 postpartum. In the antenatal period, our antenatal history goes this way. She's a mother who's 30-year-old, primigravida with good dating. She was booked and supervised at a corporate hospital. In her first trimester, she underwent aneuploidy screening with the NT scan and biochemical testing. So the NT scan was done at 12.4 weeks, which was about 1.9 millimeter in thickness. And the nasal bone was identified. It was seen. It was 2.3 millimeter with normal ductus venosus flow and with no evidence of tricuspid regurgitation. Her biochemical test, or the dual screen or double marker, what we commonly call it as. So it usually measures free beta HCG and pregnancy-associated plasma protein type A. These are the two biochemical tests which are done, and they were pretty much within normal limits, which was 1.2 MOM, and PAP A was 1.05 multiples of median. So based on these tests, her risk for trisomy 21 was calculated. Firstly, because of her age, it is 1:885. And per se, because of the biochemical test, the trisomy 21 risk is 1:4,000. We will go in detail about how these risks and how it is calculated. Combined risk, that is age and the biochemical test combined, it gave a risk of 1:8,543, which is way above the, it is considered as low risk value. We unfortunately don't have much detail about anomaly scanning and further imaging or growth scans which were done. The information we have is that she was delivered by cesarean section at 36 weeks in view of growth restriction and oligohydramnios. It was a live-born female weighing 1.9 kilos with good Apgar scores. At birth, it was noticed that the baby had a mongoloid slant, depressed nasal bridge, protruding tongue with a sandal gap and generalized hypotonia, and also systolic murmur. for which further investigation with 2D echo revealed a acyanotic congenital heart disease and a small perimembranous septal BSD and also small patent foramen ovale. So coming to the index case, we will discuss it as a live born with Down syndrome, a nightmare for both neonatologists and also for the obstetrician. We'll discuss it under 4 headings. As it goes, it is antenatal risk factors for this. What is the present Down screening technique which has to be equipped? And what are the possible causes for missing in this index case? And what is the plan for future pregnancies? I will keep it very crisp and short. So coming to the risk factors, as we know, it is the advancing maternal age. I've mentioned it as advancing maternal age because with every age group, there is an increase in risk of Down syndrome. So there is no cutoff, as in we can say that at 30-year-old, the risk is very low, or 35, the risk is very low. We can't say that. With increasing age, there is an increased risk. Previous pregnancy, if the fetus had a Down syndrome, there is a risk of recurrence. And of course, it is 0.75% higher than the maternal and gestational age-related risk, which we calculate for trisomy 21 at that time of testing. For example, to make it simple, for a woman who is 25-year-old, the risk per se because of her age is 1:946, which is 0.1%. If she's had a previous baby with Down syndrome, the risk straight away jumps up to 0.856%, which is 1:117, which is a high risk category. So in these patients, straight away invasive testing is offered if they've had a previous Down syndrome baby. And also, when it comes to recurrence, when it comes to counseling, we need to know certain parts, certain major part about the genetics behind this. So in less than 5% of the couple with previously affected baby, they will have a parental mosaicism or a genetic defect which is involving in a non-distinction process. This is the one which leads to recurrence. Otherwise, in more than 95% of the couples, it just presents as a one-off event, and the risk of recurrence is not actually increased. And of course, if the screening tests show high risk result, it means that there is a need for further testing. So when it comes to screening methods, it can be done in first trimester and second trimester. There is a lot of research and lot of papers which are available on this. Of course, Navya madam is there with us to give us in detail perspective about this. So I'll go with what is done in first trimester. It is the ultrasound and biochemical testing, which was both done in our index case. It is very important to counsel the patient before we go ahead with this, especially in the periphery where we come from. There is a cost constraint. Patient might hesitate to pay 2,500-3,000 rupees for a dual marker, but it is important to counsel them as in what we are trying to test here and how the risk is going to be categorized. So always when the risk comes up as a high risk, it is always better to have a plan before even the test is done, so that the patient is not startled by the result. Of course, after the test is done, if it comes as a high risk or an intermediate risk, we will go with counseling for further testing. Before we understand what are the different screening methods, we need to understand certain terms. There is a patient specific risk which is calculated for each and every patient, each and every sample that we send. So how is it done? It is based on 2 things. One is a background risk that is called as a priori risk, which is based on huge number of studies which are conducted on pregnant ladies to get a particular risk for particular age and gestational age. And likelihood ratios is nothing but a ratio here. Like, how is it calculated? Suppose we want to get a likelihood ratio for say echogenic bowel or a echogenic cardiac focus. So we need to calculate it on this in this way: percentage of chromosomally abnormal fetuses with echogenic cardiac focus divided by the percentage of normal fetuses with echogenic cardiac focus. This is how a likelihood ratio for a particular measurement or a particular sonological finding is measured. So coming to the screening methods, first is the maternal age and gestation. We see here in the graph on the left-hand side that the trisomies and monosomies and triploides, they all increase with maternal age. On the right-hand side, suppose if we consider at 12 weeks for a 20-year-old mother, the risk of trisomy 21 per se because of her age is 1:1068. Whereas for a 35-year-old, it is 1:249. And as the age advances, it goes further high up. So there is no definite age cutoff for invasive testing. It's not like only if the mother is 35, we offer invasive testing. Otherwise, we can just let it alone. It is not that way, because 70% of the affected babies who are born to women less than 35 years of age, they have Down syndrome. It's Down syndrome is seen in 70% less than 35 age of the mother. Maternal age should be combined, of course, with the other screening modalities to get the final risk ratios. When it comes to gestational age, there is a decreasing trend. As the gestation advances, there is a decreasing trend of detection because of the spontaneous fetal death that occurs. So in between 12 and 40 weeks of gestation, the spontaneous fetal death rate is about 30%. If the mother goes for, if she opts for not going for invasive testing and she just decides to keep the pregnancy going, there is a 30% chance that there can be a spontaneous fetal death. Then coming to the trimester 1 ultrasound, usually done in between 11 to 14 weeks, that is the recommendation. We look for certain very important parameters. One of them is the fetal nuchal translucency. I would not go in detail about this because Navya madam is covering it in depth. It's a collection of fluid on the dorsal aspect of the fetal neck, and a measurement of more than 95th percentile is considered as significant, and it is also seen in 80% of the fetuses with trisomy 21. It is standardized, like how you should measure the nuchal translucency by the Fetal Medicine Foundation. So the gestation should be 11 to 13 plus 6 weeks. So for obstetricians who are doing general obstetric practice, it's important that we call the patient at this time for NT scan and we ask them to get their biochemical test at this particular time. We should not miss this window. The fetal CRL should be 45 to 84 millimeter. More than one measurement should be taken and the highest measurement should be recorded. It should be in a mid-sagittal section with neutral position, not hyperextended or not hyperflexed fetus. Only the fetal head and upper thorax should be included. The magnification of the image should be as high as possible and the gains should be kept low so that you avoid blurring of the lines where you are placing your calipers. Maximum thickness of subcutaneous translucency is taken, and we have to, very importantly, we have to distinguish between the fetal skin and the amniotic membrane. So this is an ideal way of measuring the This is a hyperextended and this is a hyperflexed fetus, where the measurements can go wrong. Even a small deviation from the normal measurement can give a very different risk ratio. So it is very important that it is done with appropriate training and certification. Absent nasal bone, it is again seen in about 60 to 70% of the fetuses with trisomy 21 and about 2% of chromosomally normal fetuses, that is in Caucasians. In Afro-Caribbean population, of course, because of their genetic makeup, the absent nasal bone can be of a higher prevalence. Other trimester 1 ultrasound markers are shortened maxillary length, short ears, short long bones, single umbilical artery seen in a small percentage of trisomy 21, megacystis, that's a large urinary bladder of more than 7 millimeter length, tricuspid regurgitation, and abnormal ductus venosus flow pattern. Now the last two, that is TR and DV flow, they act as very important adjuvants for risk calculation as well. So the biochemical tests are free beta HCG and PAPA as mentioned earlier. The cutoffs are free beta HCG of more than 1.8 multiples of median and PAPA of less than 0.4 multiples of median. Both these are basically proteins which are secreted into the maternal plasma from the developing placenta. So when we ask for biochemical tests, we have to send in 5 ml of serum sample. Along with this, we need to send a form. Now this form is very important where we mention the correct dating, regular cycles or irregular, what is the mode of conception, whether it is assisted conception or a natural conception. It's very important to mention whether the mother is diabetic and all these things. These parameters can actually cause a difference in your report. So we have to be very cautious when we are filling this. So this is an important slide where there's a combined screening which is followed. When we go to the last line where there is maternal age, which is combined with fetal NT and NB measurement and the biochemical markers. When all three things are taken into consideration, the detection rate is about 95%. So if this thing is done alone in the first trimester, we can detect about 95% of the cases. Suppose if there is, if the mother has not undergone a biochemical testing, even with only maternal age and NT and NB measurement, The detection rate is about 90% in these cases. So coming to the second trimester, again, we have biochemical tests and anomaly scanning. The biochemical tests are done in between 16 to 18 weeks. It can also be done between 15 to 20 weeks where if required, if there is a risk that you're suspecting. In the center, we have three parameters. One is reduced maternal serum alpha fetoprotein. The cutoffs are mentioned in the slide. Increased HCG and reduced unconjugated estriol. So these three, they together form the triple screening test. And along with inhibin A on the left-hand side, which is increased in cases of trisomy 21. So that is called as a quadruple marker. And with hyperglycosylated HCG, it forms the penta test. Coming to the detection rates, triple screen alone has got a 70% detection rate for a 5% false positive rates. Quad screen has got around 80% detection rate, and the penta test around 96% with 5% false positive rates. For a mother who's more than 35 years of age, to improve the detection rates, we need to actually consider that the false positive rates also increase. So there is one entity called as combining the first and second trimester tests. Now there is an advantage and disadvantage of doing these two. The idea behind this is to increase the detection rates by combining both the tests. Of course, there is an increased cost that is involved. And till the second trimester tests are done, the mother is clueless. She does not have a report of high risk or low risk, and she's waiting. And when we have to counsel the patient for invasive testing or further go ahead and terminate the pregnancy, doing it in first trimester is way easier, more acceptable, and less traumatic, both emotionally and from the clinical point of view, when compared to the second trimester diagnosis. Now, there is first thing is called as the integrated testing, where the NT and PAPA levels are done in first trimester, and it is combined with the quad screening, which is done in the second trimester. And at the end of second trimester testing, the risk is calculated. This has a detection rate of 94 to 96%. There's another entity where only the serum tests are combined, where the PAPA is combined with quad screening, which has got a detection rate of 85 to 88%. Here, the disadvantage is that the NT is excluded. Now, NT is not only related to trisomy 21. There are other triploides, there are other trisomies where the NT can be increased, and those might be missed if we don't do it. Next is the sequential testing. I would not go in detail about this. Trisomy 2, the trimester 2 ultrasound, which is usually done in between 18 to 20 weeks. This gives us a lot of idea about trisomy 21 phenotype. The features which are mentioned in green, they were present in our index case, like the nasal hypoplasia, cardiac defect, and sandal gap, clinodactyly. These were present in our index case, which we don't have information about the second trimester's ultrasound which was done. Other features are increased NT, intracardiac echogenic focus, duodenal atresia, which is seen in about 40% cases, shortening of long bones, mild hydronephrosis. These can be seen on the ultrasound. So apart from this, we have a lot of soft markers which are seen in the radiology. That is short femur, echogenic cardiac focus, and mild atelectasis, usually associated with trisomy 21. Ventriculomegaly and choroid plexus is usually associated with other trisomies like trisomy 18. Now, if only one of these soft marker is present on the scan, we should not consider it as an indication for invasive testing. Of course, there is something which we have to look for. If the patient has echogenic cardiac focus, we have to look for other abnormalities, whether they're present or not. If it is isolated, if it's only an isolated finding, we should just leave it alone and do not advise invasive testing for just one thing. Now, this is an interesting slide. It is very crowded, but it's a very important one. Suppose we have a short femur in the patient. The likelihood ratio for it to be an isolated marker with no other features present, only short femur. The isolated likelihood ratio is about 1.6. Now this, when you multiply it with the background risk of the patient, that doesn't seem to increase the overall risk. Or suppose if only hydronephrosis is present, the likelihood ratio is 1. 1 multiplied with the background risk does not increase her overall risk. So if the features are presenting together, then it increases the likelihood ratio and thus increases the risk of trisomy 21. So the risk is categorized as follows. This is recommended as per the Fetal Medicine Foundation. So the high risk is nothing but the risk less than 1:250. In these cases, we have to offer invasive testing for further diagnosis to confirm it. Of course, with good counseling. Intermediary risk is where 1:250 to 1:1000. In these cases, we can offer invasive testing versus NIPT. We'll go in detail about that. And low risk cases are the ones where the risk is more than 1:1000, which was there in our patient. Her combined risk was more than 1:8000, and so no further intervention was done. For confirming the diagnosis, we have invasive and non-invasive methods. Invasive includes the chorionis villus sampling, which is done after 11 weeks. Amniocentesis done after 15 weeks, and NIPT can be done at 10 weeks. If CVS performed less than 11 weeks, it can be associated with microglossia, micrognathia, and limb abnormalities. And amniocentesis at an early age of less than 15 weeks is associated with increased fetal loss and talipes equinus varus, and hence the gestational age cutoffs are mentioned when what has to be done. So NIPT, what is the idea behind NIPT? So here it is said that 5 to 20% of the cell-free DNA which is circulating in the mother's plasma, it comes from the fetus. Now, isolating a fetal cell from the maternal plasma or maternal blood will be difficult because it is present in a ratio of 1:10⁷. So isolating that one cell might be difficult. So cell-free fetal DNA is an easier option compared to that. The levels of this is said to increase until 10 weeks, and thereafter it plateaus, and again in the third trimester, the levels will increase. So at 10 weeks, it is appropriate to do the testing, whatever we are looking for. Now, NIPT can be used for blood grouping, for sex determination. It can be done for single gene disorders, and also for all the trisomies. So it can be used for this at 10 weeks. So the overall test accuracy for trisomies is said to be more than 98%, and it is currently being used as a routine screening in US and China. So when we do NIPT for trisomy 21, there are 3 possible results. One is a positive result, one is negative and inconclusive. Now, when there's a positive result, we have to go ahead and still do the invasive testing to confirm our diagnosis. If it is negative, it is unlikely that the fetus does not have Down syndrome, and it can be inconclusive in 4% of the cases. This can happen when the amount of cell-free fetal DNA in the plasma is not good enough or enough for us to do the testing. This can be inconclusive. So even in case of inconclusive results, you can either repeat the NIPT or straight away go ahead with invasive testing. So the biggest question is, what are the possible causes for a live-born coming out with Down syndrome? This can happen if the screening is not done at all. This happens with most of our patients. We receive patients in third trimester, especially in the villages, especially in the peripheries. There nothing is done, and straight away they come to us in third trimester where screening is not done at all, which was not the case in our index patient because the screening was done. And incorrect screening. Now, incorrect screening can be because of multiple reasons. If the measurement is not taken properly, or if it is done at a wrong gestational age, or if it is not good enough or training to do the particular scan, this can also give rise to incorrect screening. And also it can happen in screen negative patients where everything is done and even no markers were picked up in the second trimester screen, and all screen negative patients, they might also end up with having a Down syndrome baby. So what is my plan for future conception? She needs a genetic counseling in her preconceptional period. This, of course, requires full chromosomal analysis of the baby, which is already present with Down syndrome, and chromosomal analysis of the parents in order to know what is the cause, whether there's mosaicism, whether there is a translocation. We need to know these things before we go ahead with genetic counseling and risk stratification. We have to offer invasive testing or NIPT as per the patient's choice after counseling the patient. Suppose invasive testing is straight away what is offered, but NIPT in cases where it is a precious pregnancy, if the patient doesn't want to have that risk of fetal loss or miscarriage after the invasive testing, then NIPT might be considered, and give her high dose of folic acid, 5 mg. So my take home message would be, risk analysis should be done as soon as you receive the patient in first trimester. In the absence of national screening program, we have to devise our own program and to adapt to our clinical practice. And we have to seek help from experts, whenever we have a doubt on a scan report or on a particular finding, we have to go ahead and take help from the experts. And of course, patient's counseling is very, very important. Thank you.
Yeah, that was very well covered, Doctor. Like you have covered everything about the screening and different soft markers and very strong markers and all that. So I just want you to comment on, suppose you're diagnosed Down syndrome in this patient, and then you are offering termination to the patient, because we need to explain that, either you get the choice is there whether to terminate or to continue. So
Yes,
when you terminate the patient and terminate the baby and the abortus comes out, what specific test we need to do? We need to confirm, isn't it? So we need to do a placental biopsy or a 12-weeker or 13-weeker. Should we send the whole specimen? How do we send it? And what tests are we asking? Are we just asking for only karyotyping or any mosaicism? Because as you rightly told, that there are some variants of Downs in which the recurrence risk is much more than the other one. So Dr. Navya also can contribute. So how do you, once you diagnose and then once you terminate the fetus, what test we are going to do on the fetus, on the specimen? How do we give the specimen to the genetics lab? So that, and what test do we ask? Should we ask for a
we definitely need a karyotyping on the fetus that is being terminated. And I think we have sir from genetic part as well. So they can, I think, give us insight.
So I think he's going to talk about it, isn't it?
Yes. No.
Yeah, perfect. Thank you so much. Thank you.
Thank you,
ma'am. Dr. Navya, can you share your screen?
Yeah.
Navya actually obstetrics and gynecology, and she also has a fellowship in she also has a 2-year fellowship on fetal medicine and high-risk pregnancy. I think OBGYN pediatricians, we know that our branch is not an end branch, no more a end branch. We have several super specialties these days, especially since the last decade. I think over to you, Dr. Navya.
Yeah, thank you so much. So wonderfully covered by Dr. Amrutha. I just want to summarize what she has just left. She has told us that there is, so according to the serum testing, what is there right now in clinical practice is a simple combined test to be offered for all women across all ages. That is the best test with a 95% accuracy. By chance we are missing that bus, we have to do the quadruple test, which has an accuracy of 80 to 85%. Triple marker now is outdated. Dr. Amrutha enlisted a set of tests where there is contingent screening, combined screening, where the first and the second trimester reports are combined and a risk is given. Right now in India, in government setup, they are not doing any screening for Down syndrome. In any private setup, we don't give a first and second trimester combined report because it is time consuming and more expensive for the patient. Third thing I want to tell is now the NIPT test is called the NIPS. Standing yes, they have changed from testing to screening to emphasizing.
Your screen is not moving. Is it possible to?
Yeah, I was just summarizing Dr. Amrutha's
Sorry, madam. Sorry.
So NIPS to state that it is a screening test and not a diagnostic test. Let me add some fetal medicine perspective for Down syndrome screening. Of course, our fetal medicine starts off with all the scanning. So the NT scan, where the emphasis is usually on Down syndrome, is no longer only for Down syndrome screening. It also serves to confirm the viability of the baby. It is an important time to date the baby, to see the number of fetuses, what is the chorionicity. Screen for chromosomal disorder apart from Down syndrome, that is trisomy 18, 13, and also to look for any gross fetal abnormality. We can catch 70% of the abnormalities in the baby related to the heart, the neural tube defects, any gross limb defects can be caught during this window. So NT is, of course, any measurement in ultrasound. It can be the nuchal translucency, the identification of the nasal bone to look for the regurgitation across the tricuspid valve. The specialty in fetal medicine is we are dictated by a set of rules. So only when we follow these rules, we are going to get ideal measurements such as the NT. So if I report an NT has 1.2 and somebody else reports an NT has 1.6, you will ask me, madam, is it required that what is the need for such a perfection? So we actually had a study which showed that the inaccurate measurement of the nuchal translucency makes a huge difference in the calculation of the risk, the final risk that is assigned to that baby. An error of as small as 0.5 mm causes a negative impact on the detection of anomalies. That is the importance of the right measurement of the NT. So how much is abnormal? At any gestational age between 11 to 6 to 13 plus 6 weeks, if the NT is more than 3.5, definitely it is abnormal. In any other gestational age, if you want to know if the NT is abnormal, there are many websites which give what will be the centile of nuchal translucency at that gestational age. And if it is exceeding 95 centile for that CRL, then it is called abnormal. So as the measurement of the NT increases, the risk of anomalies increases. You can see in this box, if the NT is more than around 4, then the risk of associated abnormalities is more than 90%. If the NT is quite less, means it is just above the 90th centile, the risk of major abnormality is quite less. So the importance of this box is that though your NT is abnormal, it doesn't mean that this baby is definitely going to have an aneuploidy or any major abnormality. Nearly 80 to 90% of the cases, depending upon the measurement of the NT, the fetus might turn out to be normal. So here comes the importance of the workup, the further scans, the follow-up, counseling, to be patient enough so that we don't end up terminating a normal baby because of undue suspicion. So once the NT is more than 95th centile, or the combined test risk is more than 1 in 250, means this come in high risk. So let me tell you, in India, this cutoff risk is taken from UK, that is 1 in 250. In India, a few of the centers follow 1 in 100, more than 1 in 100 has high risk, and between 100 to 1000 has intermediate risk. That really differs from center to center. So if it is coming at a high risk, we need to do a karyotype or a chromosomal microarray. What is so special about this chromosomal microarray? It gives around 10% extra detection rate for minor anomalies in the baby. Preferably, a chromosomal microarray should be done. If not available, a karyotype, which will be a slightly cheaper test, we can do a karyotype. If it is abnormal, depending upon what abnormality it is, we should counsel the baby, and if they opt for termination, it is their choice. If it is normal, which is the case in most of the babies, the karyotype and chromosomal microarray might turn out to be normal. Then we still follow up this baby, do an early anomaly scan, meaning at around 16 weeks, we follow up with the fetal echo. And if the corresponding measurement for the NT in the second trimester is the nuchal thickness, the nuchal fold thickness, if it is still high, we might also consider something testing for the Noonan's panel. And still everything is normal, it is worth to mention it to the pediatrician in the postnatal period, so that they will also do a postnatal follow-up of the baby. So one easy question that we often get asked by the patient is, if the NT is too high, of course they are hesitant to go for an invasive test in form of a chorionic villus sampling or amniocentesis, which is required for our karyotyping or chromosomal microarray. One patient is going to ask us, if the NT is more than 95 centile, can I just go for a NIPS, which is a non-invasive test by drawing blood? So there are studies that have been done. if we go, NIPS will not be appropriate for such patients. So we will be missing lot of anomalies if we choose for an IPS instead of a invasive test. Also remember, NIPS is 99% sensitive. For which anomaly? It is only for Down syndrome. And for trisomy 13-18, it is around 97%. Also, if it is positive, you can decide for a termination. If it is positive, you cannot directly go for a termination. You have to do an invasive test, confirm the diagnosis, then only you can decide for a termination. If it is negative, it is supposed to have a very good negative predictive value. So you can consider the NIPS and continue the pregnancy. Still, you will be missing some of the anomalies which could have been picked up by the invasive test. Now let us go to few of the markers of the first trimester. Nasal bone. Absent nasal bone creates a lot of panic both for the parents and for the mother. I'm sure most of the gynecologists are aware. Still, I find this question. First thing the patients want to know is the baby going to look abnormal because of unossified nasal bone? Definitely no. It is only a difference in the calcification of the nasal bridge. It is not an absent nasal bridge, so the baby is going to look absolutely normal. Dr. Amrutha rightly said that in the Caucasian population, around 3 to 5% might have an absent nasal bone. African race a little higher. So we are interested in the Asian race. How common is it in the normal babies? How common is the absent nasal bone? It is around 6 to 10%. And an isolated absent nasal bone is never an indication for termination of pregnancy. Along with a normal biochemical test, if you have an absent nasal bone, measure the NT, do a good gross anatomical scan of the baby at 12 weeks. See what is the biochemical risk. Usually it will be the double marker risk. And if this combined risk is low, you can follow up the patient, give an option for NIPS, early anomaly scan to reconfirm if it is an absent nasal bone at around 16 weeks. Only if it is persistently unossified nasal bone, then you can go for an invasive testing. Isolated unossified nasal bone is never an indication for termination, especially in the NT scan, where it is not actually an easy assessment. It requires very good technical skills and it has a lot of inter-observer variation. Never jump for termination for an unossified nasal bone. You have heard of other markers similar to absent nasal bone in the first trimester is the pattern of ductus venosus flow and the presence or absence of tricuspid regurgitation. I won't elaborate how it should be measured. Both of them have very specific instructions how they have to be measured. And if these are abnormal at 11 to 13 weeks, it adds up to the risk of Down syndrome. So what is the advantage of looking into the nasal bone, the tricuspid flow and the ductus venosus flow? It increases the detection rate of our combined test. Combined test is the PAPE, beta HCG, NT, along with the nasal bone, tricuspid, ductus venosus. It increases the detection rate for Down syndrome and decreases the false positive to 2.5 from a routine NT scan. So by combining all these markers, we are giving a more accurate test for you. So by getting a combined risk, of course, we stratify the patients as high risk, low risk, intermediate risk. Intermediate risk have an option to go for the NIPS. High risk will have to go for a invasive testing. Remember that the risk of Down syndrome in general population is still 1 in 800. Considering an average age of 30, it is around 1 in 800. do you know what is the incidence of gross anomalies in the same population? It is around 2 to 3%. Gross anomalies meaning some cardiac defect, neural tube defect, spinal anomaly, or a limb reduction defects. These defects combined are much more than the Down syndrome risk. So the screening is not all about Down syndrome. The main focus should also be at looking at the gross anomalies, and by catching these gross anomalies early, we will give an option for the patient for early termination, and also it will aid in the diagnosis of Down syndrome, where even 20 to 30% of the Down syndrome babies, apart from these subtle markers, they can also have gross abnormalities. So don't forget looking at the gross abnormalities. So what is the ideal time you're going to send your patient for an NT scan? So this slide shows you what is the detection rate of various abnormalities between 11 to 14 weeks. It also has a lot of inter-observer machine variations, but on an average, 70 to 80% of the gross abnormalities in the fetus can be found out during this window. And the best time to do an NT scan is between 12 to 13 weeks, where we will be able to do a good gross examination for anomalies. We will be able to get the baby in a more neutral position for a very good NT and for a good measurement of CRL. So the conclusion about the NT scan is, so the NT scan is a great opportunity for overall fetal assessment. Don't panic for isolated soft markers. Follow protocols, audit the scans, and always try to find a balance between undue anxiety and false reassurance. Coming to the second trimester, we all know that we do a target scan, anomaly scan. Also, it is also sometimes known as the genetic sonogram or the TIFA. What is the role? The main intention is to look for gross abnormalities. Along with that, we do something known as the genetic sonogram, where we are looking for something known as soft markers. What is this genetic sonogram? Actually, it is a mathematical formula which is based on all this second trimester markers, which revises the a priori risk. A priori risk is either the risk based on age, or if that patient has done a combined test in the first trimester, that will be her a priori risk. A priori risk is the risk before you start your genetic sonogram. In genetic sonogram, we are looking for something known as soft markers. What are these soft markers? They are small anatomical variants. They are by themselves not malformations. They can be found in normal babies as well, in 15% of the normal babies, but more so in babies carrying aneuploidy. Mainly, we are focusing on Down syndrome. These are often picked up very easily, but we end up not knowing what we should do with these markers. So we have a list of markers. Which are the 4 most important ones? Please remember, it is ventriculomegaly, unossified nasal bone, high NFT, and aberrant course of right subclavian artery, which is illustrated here. Earlier, we used to have, even now, many centers follow. There is some, they give a Down syndrome scoring, where they give a number for each one of the markers, and they give a score for you as high risk, low risk. So this is a good method, but it is quite outdated. So this is the list of various aneuploidy markers which have already been discussed with Dr. Amrutha. So I won't be discussing how to see each one of these markers, but just know that again, measurement of these markers and the way it has to be seen is standardized, and this is very important so that we don't do a false positive reporting. First is the high nuchal fold thickness. Anything more than 6 mm, between 15 to 20 weeks is abnormal. It is one of our major markers. It has a high likelihood ratio for Down syndrome. Mild ventriculomegaly, the size of the lateral ventricles is measured at the level of the atria, and anything between 10 to 15 is known as mild ventriculomegaly. Anything above 15 is an indication that there is some gross anomaly in the within the brain. Various reasons can be there for that, but here it will be called a soft marker only if it is mild, that is it is between 10 to 15. See, it is of course one of the major markers for our Down syndrome, but also it can be associated with a number of other things like torch infections, intracerebral bleed, or some cortical migration disorder. Microcephaly can be associated with that. So, if any one of the soft marker is found, we should carefully look for other soft markers, and also we should look for other major abnormalities in the baby. For each one of the soft markers, there is a set of things we have to give. For example, if there is a mild ventriculomegaly, we will have to do a detailed neurosonogram. Of course, we will advise a karyotyping. We will rule out torch infections. If indicated, we might even suggest fetal MRI. Absent nasal bone, if it is absent or subossified nasal bone, if the length of the nasal bone is less than 2.5 centile, for that gestational age, it is abnormal. See, Indian babies have a different chart for the length of the nasal bone. So don't get panicked. Always check with the, I will share in the group what is the normal for Indian babies, and always use that chart when you are looking for hypoplastic nasal bone. Absent nasal bone, not an issue. Aberrant course of right subclavian artery, again a major marker, requires careful examination of the heart. Also important to rule out other major anomalies of the heart. Hyperechoic fetal bowel can also be associated with some intrauterine bleeds or with IUGR. Again, it is one of the minor soft markers. Renal pelviectasia, often reported 99% of the mild renal pelviectasia resolve. Around, of course, there is it is a mild marker for aneuploidy. Rarely it can progress, depending on, apart from pelviectasia, we have to see how is the renal parenchyma, how is the ureters, are they dilated, is there any obstruction at the level of the bladder, what is the sex of the baby. Also we can just note, because it is more associated with males, we can see if there is any genital abnormality. We have to note all this. We need not have to report. We have to follow up at 28 weeks to see if it is progressive. Again, if it is normal at 36 weeks, we also use a classification which is similar to the neonatal classification. We use the UTD classification, which is supposed to, the same classification is supposed to be used in newborn, so that we can communicate well with the pediatricians. Short humeral length and femoral length can be associated with certain lethal and non-lethal skeletal dysplasia. Again, one of the markers for Down syndrome, it is a minor marker. Echogenic intracardiac focus often creates a lot of panic when isolated. It is a very unimportant marker and should not create, we should counsel such that it should not create any panic in the patient. Very similar to that, the choroid plexus cyst, the way we put it across to the patient, we say that there is a cyst inside the brain, which is it is very scary to hear. We should be very careful when we put it across. Most of the times by 24 to 26 weeks, they tend to resolve in 99% of the patients. We have to counsel that it is a very transient finding and it has to be reported. That is the reason the radiologist or the fetal medicine specialist has reported, and when isolated, we don't have to worry about it. There are other markers which is not very important. Only the first 4 major markers I have described. Okay, what are the limitations of these soft markers? Remember, all these soft markers have been tested and reported from retrospective studies from tertiary centers, usually fetal medicine centers. So usually they get referral cases or very high risk cases, and this data might be misleading. So the soft markers might be not so high risk the way that we are imagining, but we will have to work with whatever data we have right now. There is no fixed standardization for definitions. There will be population variation, so we should always consider our Indian scenario. So not everyone does a routine genetic sonogram as a part of their fetal anomaly scan. So sometimes you will have to mention, please give us a fetal sonogram report. So this is a very recent study in 2013 where there has been a meta-analysis on the second trimester markers. So what it is giving, so Dr. Amrutha beautifully explained what is this likelihood ratio, what is positive likelihood ratio, negative likelihood ratio. Positive likelihood ratio increases the risk of Down syndrome in your baby. Negative likelihood ratio decreases the risk. So they have given us a list of sonographic markers and what is the negative and positive likelihood ratio and the combined likelihood ratio for each of these isolated markers. You don't have to worry about the numbers. I will tell you what we do with it. So if a likelihood ratio is more than 1, it increases the risk of Down syndrome. If it is 1, it is of no diagnostic value. If it is less than 1, it decreases the risk of Down syndrome in your baby. I will tell you how it works. So you have a priori risk. You have to calculate what is the likelihood ratio from the genetic sonogram, and it will give you a revised risk. So I will explain this with an example. Today afternoon I have done this scan. So this is a 26-year-old lady, 20 weeks plus 5 days. What I have noticed that there is mild ventriculomegaly. Both ventricles you can see in this first image, it is around 10.5 to 11. Both ventricles are between 10 to 11. So it comes under mild ventriculomegaly. You can see in the second image, the renal pelvis is dilated. So if it was an isolated renal pelviectasia, I would have just asked for a follow-up. Any case of ventriculomegaly, I will be very careful. I will have to do a detailed neurosonogram. Since I have noticed ventriculomegaly, I have done a detailed neurosonogram. So I will have to rule out, is there any corpus callosal abnormality, posterior fossa defect, spinal defects. I have to measure what is the length of corpus callosum, because sometimes if not absent corpus callosum, there can be partial agenesis of corpus callosum. I have done all this and I have noted that it is isolated mild ventriculomegaly because there is no other abnormality apart in the brain apart from mild ventriculomegaly. I have searched for other aneuploidy markers. I have found renal pelviectasia. Next, what I do, from the chart before, we have algorithm that comes ready-made. I don't have to do all this mathematics. I have an Excel sheet which I can share. So I have seen what is the likelihood ratio, positive likelihood ratio for the presence of lateral ventriculomegaly. Along with that, I have multiplied with the likelihood, positive likelihood ratio of the renal pelviectasia. And the combined positive likelihood ratio will come around 200. But how the genetic sonogram works, these two markers are present. Rest of them are absent. So I have multiplied with the negative likelihood ratio of all other markers, and I will get a combined likelihood ratio of 31. This I have to divide by the a priori risk. Don't worry, you don't have to do so much of mathematics. There is a simple Excel sheet where you have to fill your data and it will give you the final likelihood ratio, and you have to divide this number with your a priori risk. For this patient, she has not done any first trimester screening. So based on her age, her risk was around 1 in 1,000. So when I divided by the combined likelihood ratio, I got a number of 1 in 34, which gets her into the high risk. So I have suggested for amniocentesis for chromosomal microarray and karyotype. Looking by all our statistics, we know that mostly this is going to turn out to be normal. Still, we can't forget the ventriculomegaly that was there. It can evolve into migration disorder. Migration disorder means the pattern of sulci and gyri is abnormal. The baby might have some developmental anomaly. It can have some low IQ. We have to follow up this patient. There is a risk of torch infection, though I don't see any markers like intracerebral calcification, microcephaly. I don't see all that, but still it can be a risk. So I have advised, you do amnio for chromosomal microarray preferably. Along with that, you do a TOT screening. You have to follow up any finding. When you are reassuring the patient, we have to tell, looks normal at present. Wherever you see my report, you will see, yeah, normal at present. No intracranial hemorrhage at present. I don't know what is going to happen in the future. I need to follow up every 3 to 4 weeks. That is how we counsel. We have to explain the patient that there is a limitation for all technology that we have. Yeah, so the current role of genetic sonogram, it is for genetic screening when there is borderline results, especially from the first trimester or second trimester serum screening. So there are many factors that is going to affect the accuracy. First of all, our biochemical screening has to be done well, depending on the maternal age, depending on the scan conditions, the weight of the mother, the obesity, all makes a difference in the final interpretation of the genetic sonogram. Remember that if all the soft markers are absent in your baby, then there is 7.7-fold reduction in the risk of trisomy 21 if there is absence of markers. So also, if there is a intermediate risk in your quadruple test, you want to reassure by using the genetic sonogram, then it will be useful. If an NIPT has been done and if there is an isolated soft marker, then we don't attach any significance for it, because genetic sonogram picks up Down syndrome in 80 to 90% of the patients. NIPT, we know, has an accuracy of nearly 99%. So considering this, if the NIPT is negative, then we won't attach any importance if it is an isolated soft marker. First rule in any investigation is don't create undue panic. If there is an isolated soft marker like choroid plexus, echogenic cardiac focus, even for that matter, isolated mild ventriculomegaly with no associated anomalies, then learn to counsel that at this point there is no indication for any undue intervention. Because as doctors, with all this technology, with this teamwork, with the communication that we have between interdepartments, we have a lot of power to detect a lot of abnormality and serve the patients for the best of our ability. But with great power comes great responsibility. Thank you so much. And I have left one question unanswered. Chandrika madam was asking, what test are you going to do on the abortus? Usually they antenatally, if the Down syndrome has been confirmed by amniocentesis or chorionic villus biopsy, there is no need of any further testing on the abortus. Only in this scenario, it should be quite unlikely that they, out of soft markers or something, they terminated the pregnancy. That should not happen. Just because there was multiple soft markers, we should not terminate. We should diagnose before we terminate. What will be the importance of the karyotype? There is one type of Down syndrome which is known as the translocation Downs. Around 5% of all the Down syndromes are caused by translocation Down, where one of the parents can be a carrier. In the karyotype, if we come to know that there is a translocation Downs, we should go back and test the parents, because it is in such parents that there will be high risk of recurrence in subsequent pregnancy. Dr. Amrutha rightly said that there is no recurrence risk in normal Down syndrome babies, but when it is translocation Downs, definitely there is a high risk of recurrence. Thank you so much.
Thank you, madam, for that fetal medicine perspective. We have learned a lot as pediatricians as well. I'll handle the questions later. I think we'll have the last part, that is the pediatric perspective. I think, Sandeep, you can be brief there. And after that, I think I'll have Dr. Vinu Adam's comments as well. Sandeep, you can start. Unmute yourself.
Thank you, sir. Good evening, everyone. I'm going to present about the neonatal and pediatric perspectives of Down syndrome. As Amrutha ma'am and Navya ma'am has covered the obstetric part and fetal medicine part of the Down syndrome, we are going ahead to see a baby we have already received with Down syndrome. Then what else we can do with the child, and what are the factors we'll encounter in a counseling baby parents with Down syndrome. These are the objectives. The introduction, which is already done very well by Amrutha ma'am. We're going to see the risk factors, few points regarding the genetics, clinical features, what are the tests to do antenatally, has already been done. What are the postnatal tests we are going to do to confirm the diagnosis of Down syndrome, we are going to see, and what are the principles of counseling, and about the next pregnancy which are associated with Down syndrome, regarding follow-up, and what are the support groups we are having in our country for the wellness of Down syndrome. This is the same case scenario which was discussed by Amrutha ma'am. In this, we are going to discuss about the once the child has received, we are going to discuss the neonatal part of the Down syndrome. The same baby, it's a 30-year-old primary mother with 36 weeks of had spontaneous labor pains, weave of oligoidomness. The mother had LSCS and had delivered a female baby with birth weight of 1.91 with normal Apgar scores, and the clinical examination was suggestive of Down's phenotype. Then how we have to proceed? As introduction was already given by Amrutha ma'am, I'll go further. These are the risk factors which can lead to development of Down syndrome in pregnancy, that is increased maternal age. Once the maternal age has increased, there will be older eggs have greater risk of improper chromosomal division, which can lead to non-disjunction. And mothers who already have a Down syndrome further increase the risk. And parents who are the carriers for translocation can also pass through babies. This is called as familial Down syndrome. This is a maternal age-related risk factors. We can see once the maternal age is 20, then the risk is around 2000, 1 in 2000. And as the maternal age progresses, the risk will increases. We can see once the maternal age reaches 40, then the incidence of Down syndrome will be 1 in 100. When coming to few aspects about the genetics of Down syndrome, the genetics in Down syndrome was Dr. Jerome Lejeune in 1950. Partial or complete third copy of chromosome pair. We can see there are 200 to 300 genes have been identified in chromosome 21, which are responsible factors leading to development of syndrome. And in trisomy 21 can occur by these four things, that is non-disjunction, which is accounting for 95%, translocation accounting for 3 to 4%, and mosaic and partial trisomy is causing less than 1%. Coming to non-disjunction, it's the most common type which leading to development of trisomy 21, and it constitutes for 95%. It is non-familial. Non-disjunction, we can see 90% of this is from maternal non-disjunction and 10% from paternal. 47 chromosomes we can see once we do the karyotyping, and risk increases with maternal age, especially it is more than 35 years. Coming to translocation, 3 to 4% of translocations are lead to development of Down's phenotype, and Robertsonian translocation between 21 and other acentric chromosomes, that is 13, 14, 15, 21, 22 can occur. And there may be de novo translocations which constitute the major chunk, that is 75%, are inherited, which can constitute for 25%, and 25% of these cases can lead to inheritance from a balanced translocation carrier parent. So parental evaluation is must if carrier risks are high. This is a translocation. We can see if the translocation between 14 and 21, the carrier mother is having risk of 10 to 15%, and carrier father is 2 to 5%. Here we can observe 221 translocation is having 100% inheritance in the future pregnancies. That's why it is called as familial Down syndrome. In coming to mosaicism, it constitutes about 1 to 2%, the result of an early trisomy rescue or early somatic non-disjunction error. Difficulty to predict Down syndrome phenotype due to variable percentages of mosaicism in different tissues, usually mildly affected. As I already told, there are like 200, 300, which are present on 21st chromosome. Depending upon which gene is affected, we can see the clinical features in the baby. One more thing, that is partial trisomy. It's a rare thing which accounts for less than 1%, and there is a duplication of element segment of chromosome 21, which produces some extra copies, but not all genes are chromosome 21. If duplicated part have genes which they will express in phenotype. Coming to clinical features of Down syndrome in neonatal period, we can go through the clinical features. That is, in central nervous system, we can anticipate hypotonia, developmental delay, and poor Morose reflex at birth. And in craniofacial, there may be brachycephaly with flat occiput, flat face, upward slanted palpable fissures, epicanthal folds, brush-filled spots in the eyes, 3 frontanelles, delayed frontanel closure, frontanel sinus and midfacial hypoplasia, mild microcephaly, short hard palate, small nose, flat nasal bridge, protruded tongue, open mouth, and small dysplastic ears. Combinedly, we can't see all the features, and some of the features, depending upon the genes which are undergone abnormality, we can develop the features. These are some of the features we can anticipate in the pediatric age group, which include otitis media and hearing loss, visual abnormalities, epicanthal folds, short nasal root depth, and upslanting palpebral fissures, atlantoaxial joint instability. In blood, we can anticipate leukemias, which constitute for less than 1%, and transient myeloproliferative disorders. In GIT, celiac disorders, duodenal atresia, Hirschsprung disease. In skin, there may be cutis marmorata. And mental retardation, hypotonia, seizures, disruptive behavioral disorders in CNS, hypothyroidism, obstructive sleep apnea, short and broad hands, clinodactyly, transverse creases in the musculoskeletal system. Congenital heart diseases like endocardial cushion defects we can anticipate, which constitutes 40 to 50%, and sterility in males and delayed puberty in both males and females can be seen. When coming to dermatographics in Down syndrome, you can see excessive ulnar loops, radial loops, mainly the 4th and 5th digit, wide 80-day angle, semian crease, that is fusion of proximal transverse crease and distal transverse crease, Sydney proximal transverse crease, which crosses the whole width of palm, and triradius, that is point of convergence of 3 regions that separate almost parallel ridges. When coming to diagnosis, Amrutha ma'am and Navya ma'am has explained about the antenatal diagnostic modalities. Coming to postnatal diagnostic modalities, we mainly diagnose the child. Initially, we can suspect by clinical features, then by physiological examination, then only we can go for confirmatory diagnostic by using karyotype or fish technique. This is a simple diagram which the child with clinical diagnosis of Down syndrome, where we can go ahead further for diagnosis. If we receive any child like what we have received is with clinical diagnosis of Down syndrome, then we can do a karyotyping. If it is trisomy 21, then the risk is less than 1%. If there is translocation, that is, there will be development of familial Down syndrome, then we have to do karyotyping of parents. If we do karyotyping of parents, both the parents are normal, then in next pregnancy, fetal screening is enough. That is normal. If the fetal screening is normal, then no karyotyping is needed. If the fetal screening is abnormal, then karyotyping of fetus is required. And if there is only one parent carrier, then type of translocation is very much important. In that slide, we have seen the risk of occurrence in next pregnancy. If it is 221 is almost 100%. That's why we have to go regarding one parent carrier type. That is, in case of Robertsonian translocation, if it is 13, 14, 15, 22, then carrier mother, when the risk is 10 to 17% in future pregnancies. If the carrier is from father, then risk is 0.5 to 5% in future pregnancies. If there is translocation between 21 and 21, then the risk is 100%. When coming to principles of counseling in the case of already existing Down syndrome, we follow 3 N's, that is neutral, non-directive, and non-judgmental. What are the primary goals we are following in counseling are the delivering a diagnosis of Down syndrome. These are the aspects which we are going to see in further slides, providing information about the Down syndrome and addressing the concerns of the family members. When coming to delivering the diagnosis, these are the recommendations which we can follow so that counseling can be done with productive way. This is like as soon as possible, when we receive the child with Down syndrome, we can go for counseling, and in person, both parents together, counseling is better in their preferred language, private setup, and accurate, up-to-date, and consistent information to be given. And sensitive, caring, confident, straightforward manner is followed. A neutral language is used, and sensitive language should be avoided. Allow time for silence, validate their feelings. Local and national support groups can be explained, and books can be explained. We have to provide information about the Down syndrome. We'll be having a lot of miscommunication about the Down syndrome. The basic information like regarding the Down syndrome, like extra genetic material, like clinical chromosomal analysis, the intellectual disability to moderate degree, and developmental delay, and congenital abnormalities which we can anticipate in Down syndrome. Like we can see congenital abnormalities in 50% of 40 to 60% may have heart defects, and 12% may have genetic like gastrointestinal abnormalities. This basic information I think we can provide to the parents, and further pregnancies also we can explain to them. And we have to maintain always an act of balancing. That is, we can always tell the good things about the Down syndrome. That is, the child will be happy and trainable, more like other children the child will behave, and more time and commitment is required rather than rearing a normal. Can go to regular schools, participate in arts and sports, employed, can be independent, freedom and intimate relationship can expectancy we can give up to 50 to 60 years, and we can also give so that they can have positive hopes on their child. When coming to risk with Down syndrome, this mainly depends upon age-related risk, karyotype, result of affected baby, and the parental carrier status and translocation. Before going to medical conditions, once we have explained the risk, then we will encounter 3 types. Like in managing the next pregnancies, that pregnancy and raising the child, or continuing the pregnancy and creating an option of adoption, or pregnancy termination.
Can you come back to the follow-up slide?
Sir?
Can you come directly to the follow-up slide?
Okay, sir. This is an article which is published in American Academy of Pediatrics regarding the health supervision of children with Down syndrome. These are the medical conditions which we can anticipate in a child with Down syndrome. The highest is hearing problems, followed by this congenital heart diseases, and there is also a risk of this leukemias, which these are the some of the points which we need to know while managing a case of Down syndrome in NICU. In first month, these are the points which we have to know. That is hypotonia, the cause is central, and facial appearance we have to note down, and feeding issues can be there in some of the babies because of GERD. Duodenal atresia or anorectal stenosis can be seen in 12% of the babies. If any child with patient, then we have to evaluate for hypothyroidism, and Hirschsprung disease, and Strider because of airway abnormalities, and hematological abnormalities like leukemia risk is less than 1%, and transient myeloproliferative disorders can be seen in, and congenital hypothyroidism is very much higher than the normal babies. So we have to screen each and every child with Down syndrome with PSH and free T4 levels. And when coming to health supervision between 1 month to 1 year, like ear examination is must to look for the serous otitis media, and hearing assessment can be done at birth. If it is abnormal, then we have to repeat at 6 months and at 1 year of age. And obstructive sleep apnea, there will be frequent night awakening, daytime sleepiness symptoms can be answered, and cervical spine is again a problem. That is importance of maintaining the cervical spine in a neutral position during any anesthetic procedure, surgical or radiographic procedures to minimize the risk of spinal cord injuries. And eye examination to rule out any nystagmus, cataracts, and strabismus. Thyroid functions at the newborn screening, then we have to repeat at 6 months and 12 months. Then cardiac issues, as I already told, there may be endocardial cushion defects leading to development of AHD, VHDs, and other congenital heart diseases. And anemia can be seen, and neurological dysfunctions like hypotonia, seizures, moya disease, and myelopathies can be seen. And immunization, it is same as other babies, and regular vaccines include influenza can also be given. And there is something called as anticipatory guidelines, where it is defined as proactive counseling of parents on physical, psychological, and emotional milestones of the children, so that they are prepared and can guide their child through their events. Here are the anticipatory guidelines from birth to 1 month of age. Discuss increased susceptibility of respiratory tract infection. The importance of cervical spine. Discuss efficacy of early intervention and availability of early intervention services and therapies in the community. Then between 1 month to 1 year of age, monitor weight and follow up weight height trends at each healthcare visit. There are separate growth monitoring charts available for Down syndrome, and we can follow that. And BMI recordings to be done. Review availability of Down syndrome support groups at least once in first year of life. Review connect to the early intervention services. Review early intervention include physical therapy, occupational therapy, and speech therapy.
Can I request, because of lack of time, can you move to the last follow-up slide?
Yes, sir. This is a slide which can summarize the health supervision of child with Down syndrome. This I will share in the group. This is the slide. Follow-up of a child with Down syndrome. What are the modalities we can see every time? This slide summarizes that. That is, for confirmation of diagnosis, karyotype is S. For hearing, we have to do at birth, then review at 6 months, till every 6 months till 4 years of age, then annually. Then vision at birth, then at 6 months, then annually, and every 2 years and every 3 years, between 5 to 13 and 13 to 21 years. And thyroid function test, annually we have to do after 1 year of age. And cardiology, echo at birth, and symptomatic reviews, individual cardiac care can be done. These are this chart I will share in the group so that we can do follow-up in a child with Down syndrome. These are the supporting groups which we are having in our country and internationally for supporting a Down syndrome, which are like National Down Syndrome Congress, National Down Syndrome Development Trust, and Huddersfield Down Syndrome Support Groups. These are well supported groups which can help in raising a child with Down syndrome. Thank you.
Thank you, Sandeep, for that clear presentation on pediatric follow-up. I now request Dr. Vinu Narayan, who is actually the genetic consultant at Center for Human Genetics at Nagar, to share her challenges in diagnosis as well as follow-up. Dr. Vinu?
Yeah, thank you, Dr.
Yourself, and you can switch on your video.
Yeah, one second. Maybe you can stop presenting, Dr. Sandeep. Am I audible, Dr. Abhishek?
Yeah, you're audible.
Yeah, so I'll just go backwards because after having heard the pediatric aspects, I think I just want to add few key points. So most of our children with Down syndrome are leading close to normal life. They go to regular school, and definitely there are few points that we need to consider while monitoring a child with Down syndrome. There's a very recent article in NEJM that mentions all the follow-up protocol. And apart from that, what I want to tell is, in terms of monitoring the growth parameters, we need to follow the CDC specific growth charts for Down syndrome. And then there were a couple of points mentioned by Dr. Sandeep telling that it's a 221 translocation. I just want to correct, it's a 2121 translocation, wherein all their children, if one of the parent is a 2121 translocation carrier, all their children would have Down syndrome. And so this is about the pediatric aspect. Most things were covered. And coming to adults with Down syndrome, about 15 to 30% of women with Down syndrome can reproduce and they can have children, and about half of them, can have children with Down syndrome. And men are usually infertile, and hence they cannot have offsprings. And in terms of genetic testing, we need about 3 ml blood and heparin to do the karyotype and FISH test. Now, all of them mentioned about could it be a trisomy 21? Could it be a translocation Down syndrome? Could it be a mosaicism? Generally, let me go backwards. Mosaicism generally do not have increased risk of recurrence in future pregnancies. It doesn't even increase the a priori risk for the couple. So it's a chance phenomenon. And how do we diagnose mosaicism? It's usually diagnosed by FISH. And I saw through all the presentation karyotype microarray. Of course, FISH also needs to be added because a karyotype cannot pick up a mosaicism, which is less than 20 to 30%. So FISH is a very efficient test to pick up varying degrees of mosaicism, and it's a gold standard. Add-on karyotype with FISH is a suitable option. And generally, the turnaround time is also a difference, where FISH can give us results in 48 hours, and karyotype could be made available in 10 to 14 days, depending on whether it is a prenatal sample or a blood sample. Now, there are also risk of culture failure. In order to try and avoid culture failure possibilities that can happen with karyotype, probably microarray holds an upper hand. So generally what I'm trying to tell is a pre-test genetic counseling or a pre-test counseling is mandatory for any couple who would like to opt for some sort of prenatal diagnosis, because there are time-bound decisions that needs to be taken. Now, moving back to the antenatal scenario, in the antenatal scenario, there is journey through the prenatal screening blood test, and then positive.